So today we will be talking on current state of aspirin, primarily in secondary prevention, but I'd like to also touch upon a few slides on primary prevention for cardiovascular disease. So aspirin, as you know, has evolved in multiple areas, both for primordial, primary, secondary, and tertiary prevention. And we see it's quietly changing its profile in the use for treatment of cardiovascular disease. So in 1997, there was a Lancet article which showed the 100 years of aspirin. It started as an anti-inflammatory drug and moved towards many other conditions of cardiovascular and cerebrovascular disease. And you can see that its turnover in millions of Deutschmark was about 1,000 in 2005. So aspirin has a huge history, and it's very difficult to think that aspirin will not be used in certain areas for cardiovascular disease. So this is the aspirin trial, which made it very important for us to understand that aspirin is important for cardiovascular disease protection. And this was the preliminary findings of the aspirin component of the physician's health study, which showed aspirin was useful in reducing predominantly myocardial infarction, fatal and non-fatal. Now, the history of aspirin for the prevention primarily of cardiovascular disease have undergone a lot of trials and a lot of studies, but the three important studies we will have importance today is the ARRIVE, the ASCEND, and the Aspirin. And when you put the meta-analysis of all these studies together, what it shows simply is that, yes, it reduces some vascular events, but at the huge cost of stroke and bleeding. And that's why, in general, in the decisional pathway for the use of aspirin in primary prevention, answer is no, that you don't use it. You may use it only in a group of 40 to 70 years old who have been explained the risk of bleeding when you are taking this drug and whose treatment of cardiovascular risk factors is being aggressive for a high-risk category. Most of the other groups of patients, you have to be careful in prescribing aspirin for treatment of as primary prevention for cardiovascular disease. So it's very important for us to understand this when we look at aspirin in today's contemporary use. So as I told you, the ACC-AHA guidelines on the primary prevention for cardiovascular disease is more or less clear. That we are now talking about aspirin usage, low dose. It may be considered only for the primary prevention in select adults of 40 to 70 years of age who have a high risk of ASCVD risk, but not at an increased bleeding. That too, the evidence is 2BA. Most of the other conditions, either it's more than 70 years or less than 40 years, you would have a class 3 indication for the use of aspirin. Even for diabetes, unless it's at very high risk, the level of evidence is very soft, it's 2BA, and most other groups of diabetes, it's a class 3 indication. Now, the importance to understand is even normal people have risk of bleeding, and antiplatelet therapy, especially aspirin, could increase the risk of bleeding in these patients who are elderly. For example, in women who are age 70 to 79 years, there's a 5 bleeding events per 1,000 person years in normal people. So aspirin for primary prevention generally is only for patients who are between 40 to 70 years of age at high risk of cardiovascular disease and at low risk of bleeding. Well, the story is different if you have a secondary prevention where you have a history of heart attack, stroke, coronary artery bypass, or stent, where it's clearly indicated. And you should not take aspirin if you're healthy, over 70 or under 40 years, or if you have an increased risk of bleeding because of a medical condition or any other medication which is causing it. Now, the use of aspirin for reducing vascular events in secondary prevention has again been a long history, and this is another nice paper which came with the ATT group, the anti-trialist collaboration, which clearly odds reduction in all groups for all sorts of secondary prevention shows aspirin favorable than the placebo control. Now, the next issue is that can we drop aspirin? And this is because of the increased risk of bleeding associated with the DAPT regimen. And this is a paper just recently published in September of 2020 in the Circulation, which clearly suggests that could be drop aspirin. And the reason is, the sharper the knife, the more chance you will cut yourself. So the more stronger your dual antiplatelet therapy, the more chance that you will sort of end up with a bleeding issue. So I think that this is extremely important for us to realize that patients who have an increased antiplatelet therapy have an increased bleeding risk. So is the use of lifelong aspirin in prevention of chronic coronary syndromes, especially in patients who've had intervention, still sacrosanct, or is reprisal warranted? Now, as we said, in the secondary prevention trials, with the historical trials of aspirin after MI, it clearly showed that aspirin was important for reduction of serious vascular events and death in many of the trials. And again, when you look at this, you look at the secondary prevention trials, and you can see again clearly that this is the same story that we're getting in, that your secondary prevention trials are always showing much better difference of events as compared to the primary prevention trial. So clearly, we are in a situation now to say that for secondary prevention trials, aspirin was important. But the recent trials have suggested whether we can discontinue patients post PCI adapt among chronic stable patients, especially who are on the better antiplatelet therapy, better therapies including oral anticoagulants, especially if their bleeding risks are higher. And contemporary therapy is now very, very clearly moving away from removing aspirin from lifelong treatment for chronic coronary syndrome. So I think we have the historical aspirin trials here and the lifelong aspirin trials here, which is now being sort of questioned, and we may have this house collapsing soon in terms of the current trials which are now available. So there are numerous of these trials, and I'll go through them very quickly. But most important to say is that there was this trial, the Global Leaders trial, which compared ticagrelor for 1 month, followed by ticagrelor, dual antiplatelet for 1 month, followed by monotherapy for 23 months, showing that the events were better with the ticagrelor arm. The STOP DAPT again showing that for non-inferiority, it was superior. And clearly you can see that the STOP DAPT trial also showed that aspirin may be dropped. Both arms got ticagrelor and followed up with standard of care. And what important happened was the primary endpoint of bleeding was looked at, and ischemia was also looked at for the non-inferiority hypothesis. And clearly what you can see clearly here is if you look at the red arm, ticagrelor with aspirin had more bleeding than ticagrelor alone, while the follow-up with standard of care showed equal bleeding. So clearly this is important for us to understand. What was also important was that the ischemic events were no different whether you gave them ticagrelor and aspirin or ticagrelor plus. So a single antiplatelet strong like ticagrelor seems to be doing its job. Now, the more important thing we have to understand that these were patients with high risk events, PCI, who were taken up for this trial, and an antiplatelet therapy of a single antiplatelet showed substantially less bleeding with ticagrelor than aspirin. And it also did not increase the ischemic events up to a period of 1 year. What about diabetes? Similar results. And you can see that the death MI stroke were no different when you gave ticagrelor for and aspirin for 3 months and then followed it up with ticagrelor and aspirin versus ticagrelor and placebo. No difference in events in terms of death MI and stroke, but the bleeding was very, very significant. So clearly, what it's again showing the same story. And this is also in patients who have high risk complex PCI being done. Again, similar results, and almost in each cohort, we are seeing a consistent result that there is more bleeding if you use 2 antiplatelets and no difference in ischemia. So this is the recent trial, the TICO trial in STEMI patients who had PCI and ACS patients who had PCI. And again, the same story that you can discontinue your aspirin after 3 months and ticagrelor monotherapy seems to be good enough. And it seems to be better in terms of bleeding rather than using dual therapy in patients with PCI and ACS patients. Now, what about rivaroxaban? It also shows that in patients who have chronic stable angina without AF, you can use anticoagulant alone. And here you can see this trial, the COMPASS, which showed that As compared to aspirin alone, rivaroxaban alone and rivaroxaban low dose with aspirin was superior in terms of outcomes in the long run. So the risk reductions were much better. And you can almost think that you can do away with aspirin if you don't want it to be used either in isolation or in combination in patients with a high risk or chronic coronary syndromes. So if you look at the ASC guidelines this year for non-ST elevation MI, it's basically whether you have an increased ischemic risk or you have increased bleeding risk. The more bleeding risk you have, you use shorter dual antiplatelet therapy and you continue a single antiplatelet. Here's a very high risk bleeding. So you would not use ticagrelor, you would use clopidogrel. On the other end, if you have a middle group of patients who have bleeding risk and ischemic risk, you would need aspirin and clopidogrel, and you could use aspirin in the long run, but aspirin and clopidogrel will be for 3 months. So you're now using this first 3 months window for patients with a high ischemic risk to cover that ischemia and then follow it up with the aspirin alone. But if you have patients with a high ischemic risk, then your drug changes here or after 3 months becomes stronger, which is ticagrelor. Or you can use aspirin or ticagrelor after 6 months, or ticagrelor or placebo. This depends on what you want to use and how old the patient is. And extremely high-risk patients, you can use aspirin plus rivaroxaban for 12 months and follow it up with either rivaroxaban alone or rivaroxaban aspirin. What about AF patients? In these patients too, we have to understand the moment you have a high bleeding risk, the first drug that you throw out is aspirin. So the moment your first month is over of PCI for non-ST elevation with AF, you simply shift to dual therapy, that is NOAC with single antiplatelet therapy, and then NOAC alone after the long-term treatment. So clearly we are moving towards a scenario where aspirin is getting dropped. So my take home here is that current guidelines recommends lifelong antiplatelet therapy for aspirin for secondary prevention. This is based on historical trial data, but emerging theme from recent trials show that with aspirin discontinuation, there's decreased bleeding and no compelling evidence for excess ischemic risk in selected groups of patients with chronic stable angina. But obviously, you should understand that you have to use the alternative, more expensive antithrombotic agents. When replacing aspirin with alternative, more expensive antibiotics, remember the economic implications, especially in a country like India, have to be kept in mind. Thank you very much.